on electrolyte disorder, and today we will talk on mainly sodium disorder. Okay, and I am you will mute yourself, and at the end we will unmute to for any questions. Okay.
Okay, sir.
Now, as you know, what is the most common electrolyte disorder? Can you tell? It is mainly
hypernatremia.
okay, sodium disorder, and mainly it is hyponatremia. So hyponatremia is the most common electrolyte disorder in your clinical practice. So this is very important. Now we will go to the main topics. That is about the, as you know, in the intracellular fluid and in the extracellular fluid, which one is most common? Extracellular fluid. In the extracellular fluid, most important electrolyte is sodium, and in the intracellular fluid, most important electrolyte is potassium, as you all know. And also in the extracellular fluid, most chloride and bicarbonate are abundant. On the other hand, in the intracellular fluid, that is the magnesium and phosphate and sulfate is abundant. So you have to know where this electrolyte main electrolytes in the intracellular fluid or extracellular fluid. So in the extracellular fluid, major cation is sodium, and in the intracellular fluid, major cation is potassium and magnesium. And in the major anions in the extracellular fluid is chloride and bicarbonate, and in the intracellular fluid it is phosphate and sulfate. So this is very important when you are going to discuss about the disorder. So disorder of sodium concentration. As we all know, sodium is the principal cation of extracellular fluid, and recommended daily intake of sodium chloride is less than 5 gram salt, table salt, that is 1 teaspoonful. And sodium level are regulated by the kidneys. So, and what about the functions? It mainly maintains the water distribution and osmolality, maintenance of the membrane potential, and absorption of the chloride, amino acids, and glucose. So it is the main function of sodium. So this is a very important slide. And what is the normal level of sodium? It is, as you all know, it is 136 to 145 millimole per liter. When we level it as a case of hyponatremia, when the sodium concentration is less than 135 millimole per liter. And in hypernatremia, the plasma sodium will be more than 145 millimole per liter. And this picture is very important. So this is the normal cell, but when there is hyponatremia, more water will enter into the cell and intracellular pressure will be increased. And when there is hypernatremia, that is sodium concentration more in the extracellular fluid, more water will be shifted from the intracellular space to extracellular space, and the cell will be shrinking. So this change you will get it when there is any disorder. So usually manifestation occurs when the sodium level is less than 130 millimole per liter. As already I have told, that is hyponatremia is the most common electrolyte abnormality. And in all cases, hyponatremia is caused by greater retention of water relative to sodium. So when there is hyponatremia, actually retention of water is more than that of sodium. Urinary sodium exceeding 20 milliequivalent per liter is consistent with renal salt wasting. This is also important. And urinary sodium less than 10 milliequivalent per liter implies average sodium retention by the kidney to compensate for extra renal fluid loss. So these changes you have to remember. Now classification. According to the duration of hyponatremia, it is classified as acute and chronic. When will you label it as acute? When the time duration is less than 48 hours, and chronic if it is more than 48 hours. Then we label it as acute hyponatremia and chronic hyponatremia. Based on the biochemical findings or on the degree of severity of symptoms, hyponatremia can also be defined as mild, moderate, and severe. As you all know, when will you label it as mild? When the sodium concentration is 130 to 135 millimole per liter. Moderate, 125 to 129 millimole per liter. And severe, when it is less than 124 millimole per liter. So main features occurs when it is in moderate and severity. So symptomatology and severity of hyponatremia. So when there is a mild hyponatremia, that is 130 to 135 millimole per liter, actually there is no symptoms. In case of moderate hyponatremia, there is nausea, delirium, and headache. And in case of severe hyponatremia, when sodium concentration is less than 124 millimole per liter, there is vomiting, patient is drowsy, there may be seizure, coma, and there may be cardiorespiratory arrest. And in the ICU setting, you will frequently find such hyponatremia, even it is less than 120, 110 millimole per liter can occur in case of severe hyponatremia. Now, the algorithm, that is the approach, evaluation. How will you evaluate hyponatremia? So, first you look for serum electrolytes, that is whether it is mild, moderate, or severe. Then you measure the serum osmolality, and according to the osmolality, you will classify, that is, it is a normal osmolality or low or high. Most important is low osmolality. Hyponatremia with low osmolality, that is less than 280 milliosmol per kg. When we will label as, that is the hyponatremia despite there is a normal osmolality. When osmolality is at the range of 280 to 295 milliosmol per kg body weight, then we label it as the case of normal hyponatremia, that is isotonic hyponatremia. Where we will get it? When there is hyperproteinemia, when there is hyperlipidemia, either due to chylomicron excess or triglyceride, rarely cholesterol. So protein and fat, if that is level is high, then you will get isotonic hyponatremia. And in case of high osmolality, that is more than 295 milliosmol per kg, you will get hypertonic hyponatremia. In case of mainly if there is a hyperglycemia, or if you give mannitol, sorbitol, or maltose or glycerol. Even in case of radio contrast agent, when you use it IVU, there may be hypertonic hyponatremia. So this classification you should remember. Now comes to the most important, that is hypovolemic, that is hypertonic hyponatremia. Here again we classify according to the volume status, that is hypovolemic, euvolemic and hypervolemic. Now comes to the most important findings as we will get in case of hypovolemic hyponatremia. Here most important thing is urinary sodium excretion. When urinary sodium excretion is less than 10 milliequivalent per liter, we usually think there is extrarenal salt loss due to diarrhea, vomiting or dehydration due to other causes. Here the kidney will try to reabsorb more sodium and urinary sodium excretion is usually less than 10 milliequivalent per liter. But when urinary sodium is more than 20 milliequivalent per liter, there is we have to think whether there is any renal salt loss either due to diuretics or due to ACE inhibitors or nephropathies or mineralocorticoid deficiency or cerebral sodium wasting syndrome. So when you are getting more sodium, that is more than 20 milliequivalent per liter in the urine, you have to think there is a renal loss of sodium. So this is very important. If you can measure urinary sodium, you can guess whether the deficit is in the extrarenal salt loss or due to renal loss. Now comes to the euvolemic hyponatremia, either due to syndrome of inappropriate ADH secretion or postoperative hyponatremia, hypothyroidism, psychogenic polydipsia in case of say if a patient is psychogenic, hysteric, and the patient can take more and more water, there you will get the euvolemic hyponatremia. There is idiosyncratic drug reaction can occur, endurance exercise and adrenocorticotropin deficiency. So you will get euvolemic hyponatremia in these settings. And in case of hypervolemic, there is edematous state. So say in case of congestive cardiac failure, in case of cirrhosis of liver, in case of nephrotic syndrome, in case of advanced renal failure, there is water retention. In these particular conditions, you will get edematous state and more water is retained. Say in case of cirrhosis of liver, there is effective blood volume is less, renal circulation is less, there is activation of renin-angiotensin-aldosterone system, and there is more water retention, and you will get congestion. Similarly, we will get in congestive heart failure as well as in the nephrotic syndrome. So these are the frequent conditions you will encounter in your clinical practice. Now, what about the isotonic and hypertonic hyponatremia? Isotonic and hypertonic hyponatremia should be initially ruled out by determining the serum osmolality, blood lipids, and blood glucose. In case of isotonic hyponatremia, can be seen with hyperlipidemia and hyperproteinemia. You will get it. Marked increase of lipids, that is chylomicron, triglyceride, and proteins, that is more than 10 gram per dl, that is intravenous immunoglobulin therapy, occupy a disproportionately large portion of plasma volume. Where we are giving the intravenous immunoglobulin therapy, say even in there are many conditions, Guillain-Barré syndrome, as well as even in many other conditions you are giving the intravenous immunoglobulin, myasthenia gravis crisis, and then there is marked increase of lipids, but plasma osmolality remains normal. A decreased volume of water results so that the sodium concentration in the total plasma volume is decreased. Because the sodium concentration in the plasma water is actually normal, hyperlipidemia and hyperproteinemia causes so-called pseudo hyponatremia. So these conditions sometimes we are also labeling as a case of pseudo hyponatremia. Now comes to the hypertonic hyponatremia is the most commonly seen in hyperglycemia. Say in case of diabetic ketoacidosis, when blood glucose becomes actually elevated, water is drawn from the cells into the extracellular space, diluting the serum sodium. The plasma sodium levels usually falls 2 milliequivalent equivalent per liter for every 100 milligram per dl rise when glucose concentration is between 200 to 400 milligram per dl. But if the glucose concentration is above 400 milligram per dl, the plasma sodium concentration falls 4 milliequivalent per liter for every 100 milligram per dl rise in glucose. You will get it in this either hyperosmolar diabetic coma or in the diabetic ketoacidosis when the sugar level rises. So if it is rises above the 400 milligram per dl, then sodium concentration will fall 4 milliequivalent per liter for every 100 milligram rise of glucose. So this you should consider when you are treating a case of diabetic ketoacidosis or in the hyperosmolar diabetic coma patient. Now comes to the hypertonic hyponatremia. True hyponatremic water shifts into the cell, usually resulting in increased intracellular pressure. We have already seen in our previous slides that when there is a hyponatremia in the extracellular fluid, that fluid will enter into the cell which will raise the intracellular pressure. But when there is hypernatremia, water will come out from the cell and there is a shrinkage of the cells. So this you have to consider when you are treating a case of hyponatremia. Now comes to the hypovolemic hypertonic hyponatremia. Hyponatremia with decreased extracellular fluid volume occurs in the settings of renal or extracellular volume loss. Total body sodium is decreased to maintain intravascular volume. ADS, antidiuretic hormone secretion increases and free water is retained. Hyponatremia has been shown to develop in patients with intracranial disease through renal sodium wasting. So renal sodium loss is there if there is a brain tumor or then any head trauma or any other conditions where there is a raised intracranial pressure, there is also sodium loss in the kidney. So this can occur. Now euvolemic hypotonic hyponatremia, that is in case of syndrome of inappropriate antidiuretic hormone secretion. Hypovolemia physiologically stimulates ADH secretion. So the diagnosis of SIADH is made only if the patient is euvolemic. So this is important. If patient is euvolemic, then you can label it as a case of SIADH. In SIADH, increased ADH release occurs without osmolarity dependent or volume dependent physiological stimulation. So this is also important. Now, what are the causes of syndrome of inappropriate ADH secretion? There may be some questions even in your written exam. It may be due to tumors, say bronchogenic carcinoma or any other tumors. CNS disorder, either due to the stroke or due to infection or due to the head injury or due to the psychosis or due to porphyria. Pulmonary disorders, if there is a pneumonia, tuberculosis, obstructive lung disease, there may be a SIADH. That is, ADH secretion is inappropriately high. And there are some drugs that may also causes inappropriately raised ADH, like anticonvulsant, psychotropics, antidepressant, oral hypoglycemic agent, and opiates. So there may be a syndrome of inappropriate ADH secretion. What are the malignancy that causes high ADH secretion? Bronchogenic carcinoma, pancreatic carcinoma, prostatic carcinoma, malignant lymphoma, leukemia, and there may be also some idiopathic causes of inappropriate ADH secretion. Now, how you will diagnose a case of syndrome of inappropriate ADH secretion? When there is low plasma sodium concentration, usually less than 130 milliequivalent per liter, low plasma osmolarity, that is less than 275 milliosmol per kg, but urinary osmolarity not minimally low, typically more than 100 milliosmol per kg. So these three things is very important when you are diagnosing a case of SIADH. Urinary sodium concentration not minimally low, that is more than 30 millimole per liter, and normal plasma urea, creatinine, uric acid maybe that is low, clinical euvolemia, absence of adrenal, thyroid, pituitary or renal insufficiency, no recent use of diuretics, exclusion of other cause of hyponatremia, then you can label it as a case of SIADH. Now comes to the hypervolemic hyponatremia. This is the common findings, as already we have mentioned, in case of congestive cardiac failure, cirrhosis of liver, nephrotic syndrome. These are the conditions where you will get hypervolemic hyponatremia. This is accompanied by the edema-associated disorder, as already we have mentioned. Even in case of advanced renal disease, there may be fluid retention. That is in the term, that is in stage 5. CKD, you can get fluid retention. Total body sodium is increased, yet effective circulating volume is sensed as inadequate by baroreceptors. Increased ADS and aldosterone results with retention of water and sodium. As already we have mentioned, there is, say, in case of cirrhosis of liver, there is a full of splanchnic circulation. So cardiac return is less, cardiac output is less, effective circulation to the kidney is less. So there is activation of the renin and angiotensin aldosterone system, and there is a more fluid retention. The urine sodium concentration is generally less than 10 milliequivalent per liter unless the patient has been taking diuretics, because body will try to reabsorb more sodium to correct it. Now comes to the treatment of hyponatremia. In case of asymptomatic hyponatremia, so say in case of mild hyponatremia where the sodium concentration is only 130 to 135 milliequivalent per liter, the correction rate of hyponatremia needed no more than 0.5 milliequivalent per liter per hour. Water restriction, water intake should be restricted to up to 1 liter per day. A gradual increase of sodium usually occurs in case of asymptomatic hyponatremia. And if required, you can give isotonic crystalloids 0.9% sodium chloride with furosemide may be used in an asymptomatic patient whose serum sodium is less than 120 milliequivalent per liter. Demiclocycline, that is 300 to 600 milligram twice daily, is useful for patients who cannot adhere to water restriction. If water restriction is not possible on this group of patients, then you can use this drug. It inhibits the effects of ADS on renal tubule, distal renal tubule. Then sodium, more water will be excreted. Now comes to the symptomatic hyponatremia. Symptomatic hyponatremia usually seen in patients with serum sodium level less than 120 milliequivalent per liter. This is also a very severe hyponatremia. If there are central nervous system symptoms, hyponatremia should be rapidly treated at any level of serum sodium concentration. So only in this group of patients, when there is CNS symptoms, patient is stuporous, patient is coma, then you can give rapid correction. Otherwise, always sodium deficit should be corrected slowly, very slowly. Rate and degree of correction: central pontine myelinolysis may occur from osmotically induced demyelination due to overly rapid correction of serum sodium and increase more than 1 milliequivalent per liter per hour or 25 milliequivalent per liter within the first day of therapy. So this is very important. Remember, because if you are rapidly correct, that is sodium concentration in the extracellular space will be high, so more water will be came out from the cell, and there will be shrinkage of the cells, and that causes central pontine myelinolysis. So this is very fatal. So one should not correct hyponatremia rapidly. And hypoxic anoxic episodes during hyponatremia may contribute to the demyelination. So this is very important. So again, you must remember the sodium hyponatremia should be corrected very slowly, not more than 1 milliequivalent per liter per hour, even less. This is very important. A reasonable approach to increase the serum sodium concentration by no more than 1 to 2 milliequivalent per liter per hour, and not more than 25 to 30 milliequivalent per liter in the first 2 days. So this is very important. The initial goal is to achieve a serum sodium concentration of 125 to 130 milliequivalent per liter, guarding against overcorrection. So you must remember these things when you are correcting hyponatremia. Now, when you are giving the saline plus furosemide, that is hypertonic saline, that is 3% saline, that is 3 gram in 100 ml of distilled water with furosemide is indicated for symptomatic hyponatremic patient. So, if a patient rapidly develops neurological symptoms, rapid onset, then you can correct hyponatremia by saline with furosemide. If furosemide 0.5 to 1 milligram per kg intravenously is added to the kidney, cannot concentrate urine in the presence of high level of ADS. Infusion of 3% saline is accompanied by excretion of isotonic urine with a net loss of free water. So you can correct this within a very short time. Only for acute cases with neurological symptoms you can apply this. Otherwise, always slow correction is important. Now comes to the hypernatremia, that is sodium concentration and more than 145 milliequivalent per liter. This is actually less prevalent than that of hyponatremia. General consideration, this always indicates water deficit. So more water is lost than sodium, and intact thirst mechanism usually prevents hypernatremia. That is, when sodium concentration more than 145 milliequivalent per liter, thirst mechanism actually activated and patient is taking more and more water, so that actually prevents hypernatremia. Hypernatremia is always associated with increased plasma osmolality, which is a potent stimulus to thirst. Hypernatremia may occur in the presence of normal, reduced or expanded extracellular volume and does not necessarily imply that total body sodium is increased. Now, actually, when patient is symptomatic, actually when sodium concentration is more than 160 milliequivalent per liter, when usually in between, patient is asymptomatic. And main symptoms is due to CNS manifestation, due to dehydration of brain cell. As already we have mentioned, more water will coming out from the cell into the extracellular space, and the cell will be cell surface will be shrinking. So what the features can occur? In case of central nervous system, you can get restlessness, lethargy, ataxia, irritability, spasm, delirium, seizures and coma. Musculoskeletal system, you will get weakness. Cardiovascular system, you will get tachycardia, hypertension, syncope. And in case in tissue, that is a dry, sticky mucous membrane, red, swollen tongue, and decreased saliva and tears. All secretion will be decreased. And in case of kidney, there is oliguria, because kidney will try to preserve more water in this setting. And there may be also fever. Fever can occur. Now, what are the causes of hypernatremia? either due to ADH deficiency, that is diabetes insipidus. You will see in case of ADH has a role to preserve the water in the distal convoluted tubule. More water will be reabsorbed by if there is any deficiency, there will be more water loss, and there is hypernatremia. This is also very serious condition. And in case of iatrogenic, if you administer, that is a hypertonic sodium solution, and insensitivity to ADS in case of nephrogenic and diabetic insipidus, by if you prescribe lithium for a long time. In case of manic depressive psychosis, also there is a tetracycline, amphotericin B, and acute tubular necrosis. There is the ADS is insensitive in the distal renal tubule, so more water will be lost. In case of osmotic diuresis, in case of total parenteral nutrition, as say in case of in ICU settings, when there is a total parenteral nutrition, there is osmotic diuresis that may cause hypernatremia, and hyperosmolar diabetic coma may also cause hypernatremia. Plus, in case of iatrogenic causes, when there is the administration of hypertonic sodium solution and plus deficient water intake, if you do not intake water, then there is also hypernatremia. So this is also very important. Now, what are the essentials of diagnosis? Occurs most commonly when water intake or water supplementation is inadequate, as in patients with altered mental status. Urine osmolarity helps differentiate renal from non-renal water loss. So urine osmolarity, if the facilities are available, you should measure the urine osmolarity. Now comes to the laboratory findings. Urine osmolarity will be more than 400 milliosmol per kg. That indicates renal water conserving ability is functioning. Non-renal loss, when there is hypernatremia will develop if water ingestion fails to keep up with the hypertonic loss from the excessive sweating, external loss from the respiratory tract, or through the stool water. Say if there is a profuse diarrhea, acute gastroenteritis, if you do not if you only replace with only water, then there may be hypernatremia. Lactose causes an osmotic diarrhea with loss of free water. So if it is much diarrhea, then there may be the hypernatremia can occur. Renal losses. Whereas diabetic hyperglycemia can cause a pseudo hypernatremia, progressive volume depletion from osmotic diuresis of glycosuria can result in true hypernatremia. So here both can occur. Say if there is osmotic diuresis by glycosuria, there may be hypernatremia can occur. And a dilute urine with osmolarity less than 250 milliosmol per kg with hypernatremia is characteristics of central and nephrogenic diabetes insipidus. So urine osmolarity is usually less than 250 in case of diabetes insipidus, nephrogenic diabetes insipidus. Nephrogenic diabetes insipidus seen with lithium or demycocycline therapy, which also we usually use in case of hypernatremia. After relief of prolonged urinary tract obstruction or with interstitial nephritis results from renal insensitivity to ADS. So these conditions you should also consider. Now what about the treatment? Treatment of hypernatremia is directed towards correcting the causes of fluid loss and replacing water and needed electrolytes. If there is reason that the condition has been developed rapidly, neuronal shrinkage may be acute and relatively rapid correction may be attempted. So here rapid correction can be advised if there is a acute hypernatremia, and if you think there is a neurological symptoms, because cells will be shrinking in this condition. This is achieved by infusing appropriate volume of intravenous fluid, that is isotonic 5% dextrose or hypertonic 0.45% of saline at an initial rate of 50 to 70 ml per hour. So hypertonic saline, that is half percent normal saline you can give in such condition. In older patient, it is more likely that the disorder has developed slowly. If hypernatremia is too rapidly corrected, the osmotic imbalance may cause water to preferentially enter brain cells, causing cerebral edema, and potentially severe neurological impairment can occur. So this is all about today's lecture.